Hello everyone, my name is Amy Francie, and today I'll be presenting on the monoamine receptor hypothesis of depression. This is one of the foundational frameworks in psychopharmacology and has shaped how we understand and treat depression in clinical practice. I'll be reviewing the main ideas behind the hypothesis, the neurotransmitters involved, and the nursing implications. Originally, depression was thought to result from a simple deficiency in neurotransmitters like serotonin, norepinephrine, and dopamine. The receptor hypothesis has changed that idea by showing that it's not just about how much the neurotransmitter is present, but it's about how the receptors and downstream signaling adapt over time. When monoamine levels remain low, receptor sensitivity changes, and this contributes to the symptoms we see in depression. This helps explain why restoring neurotransmitter levels isn't immediately effective. One of the key characteristics of this hypothesis is that antidepressants increase neurotransmitter levels right away, but patients don't usually feel better until several weeks later. That delay reflects the time it takes for the receptors in the intracellular signaling systems to adapt to the med. For example, prolonged low serotonin can lead to receptor upregulation, and antidepressants gradually normalize this system. This receptor level adaptation is central to understanding why treatment response takes time. The main neurotransmitters affected are serotonin, norepinephrine, and dopamine. Serotonin, or 5-HT, is critical for mood regulation, sleep, and appetite. Norepinephrine is more involved in arousal, attention, and the stress response, and then dopamine regulates motivation, energy, and pleasure. Dysregulation across these systems, particularly in brain regions like the limbic system and prefrontal cortex, contribute to emotional, cognitive, and physical symptoms of depression. The monoamine receptor hypothesis directly influenced the development of antidepressant medications, including SSRIs, SNRIs, MAOIs, and tricyclics. It also helps us explain to patients why they won't feel relief right away because the receptor level changes require time. At the same time, the hypothesis has limitations. It doesn't fully explain treatment-resistant depression, which has led to newer models focusing on neuroplasticity and neuroprogression. As nurse practitioners, we need to use this knowledge to guide treatment planning, educate patients and families, and consider multimodal approaches, including psychotherapy and lifestyle interventions. Here's the references I used for this presentation. I used Stahl's Essential Pharmacology, Delgado's article on monoamine deficiency, and Krishnan and Nestler's review of the molecular neurobiology of depression.